Hey, welcome to BC Nephro. Thanks for watching. Today shooting this video on Memorial Day. Happy Memorial Day. I want to honor the people who I respect, who allow me to have the privilege of being able to be here and do this. Especially my brother. Thanks, bro. Today, the next in dialysis rounding primer, Dialysis Access, Arteriovenous Access. Now there's two types of arteriovenous access. There's fistula, arteriovenous fistula, and grafts, arteriovenous grafts. If you'd like to know how I tell the difference between a fistula and a graft, check the link in the description article on that. But today we're going to be talking about fistula and grafts, the benefits of fistulas and the benefits of grafts. Second, how to assess particular fistulas if they're ready for use. And third, some of the complications that you may come across. So the first, fistulas, which is a native artery to vein, are the preferred. They're preferred for a number of reasons, and native tissue is better. Native tissue is less prone to get infected. If it does get infected, it's native tissue and can be treated without removal of a foreign body. It's less prone to thrombose, life expectancy, the longest duration of successful use. So why would you want to use a graft? Sometimes the anatomy is not sufficient for a fistula to mature, so it's just not feasible. Second, the maturation process is longer for a fistula for a graft. Minimum of 6 weeks. Where with a graft you can use it quicker, certainly within 2 weeks, and then there's also immediate use of aerations of grafts. And the third is if it does thrombose, it's difficult to more difficult to declot, so there's some issues there. But in general, if you have enough lead time, if you have sufficient venous and arterial anatomy, you're going to want to go with the fistula. Now, assessment. Now, we all know assessment. Listen for a bruit, we feel a thrill, and if there's flow through it, it's patent. But that for a fistula is not really sufficient to know that it's able to be used. So there's a couple of things you're going to want to look for. First, you're going to want to hear and feel the character of the bruit. So the character of the bruit should be a continuous kind of whirring type thing with both systolic and diastolic flow. If it's more of a pulsatile systolic pulse only, that's an indication of a poor fistula, likely a venous stenosis that would need to be addressed. Second, just because there's flow doesn't mean it can be successfully cannulated. So how do you know if it's mature for use, if it can be successfully cannulated? Well, you're going to want to look at the fistula to see, do you think a dialysis nurse can get 2 large bore needles into this? So you're going to want to see if it's close enough to the surface, very bulging vein, that could happen. For a fistula, you can use a tourniquet to assess this. You're not going to want to use a tourniquet on a graft. That can cause thrombosis, but see if the vein comes up enough so a dialysis nurse can get 2 large bore needles in it. You're going to also assess for arm edema. You're going to assess for collateral veins. These could be signs of venous or outflow stenosis. So next we're going to talk about the complications. There's a number of complications. First of all, it can clot, so it can thrombose. In that case, you're not going to feel any thrill, and that would either a fistula or a graft, and that would need to be sent for thrombectomy. I would say if it's a fistula, try to get the thrombectomy more urgently. Those are more difficult to declot. A graft, you may have a little bit more leeway in that. The second can be a stenosis. So the stenosis can be a venous or outflow stenosis or a central stenosis. And it's important to pick these up, as it can be a precursor of graft thrombosis, and if you can correct that, you may, or fistula thrombosis, and if you correct that, you may be able to prevent a thrombosis. So what are you going to look for that? So first, if the thrill or bruit is as a pulsatile character, that's going to be one sign. Another sign is if there's arm edema or collateral veins, that's a sign that there may be a central stenosis. A third sign would be if there's increased bleeding post-dialysis. That can be a sign of a venous stenosis and back pressure. A fourth sign is if there's really underdialysis. So if the dialysis kinetics are suboptimal, check a link for our article on Dialysis Kinetics. Or if there's hyperkalemia, that can be a sign that the fistula is dysfunctional. If there's a venous stenosis, there can be recirculation, which essentially means you're dialyzing the same blood over and over again, so you're not getting the clearance from the body. So those are some of the things for stenosis. Next thing you're going to look for is infection. So infection may present most likely as fever and chills with dialysis. Then you do cultures and there's a bacteremia. There may be a drainage, maybe a fluid collection there. So those are some of the things to look for infection. The fourth thing, either an aneurysm or a pseudoaneurysm. So if it's a fistula, it's an aneurysm. If it's a graft, it's a pseudoaneurysm. But in any event, it's an expanding dilatation of thin skin, and it's important to look out for these because if it bursts, that's a problem. If the patient's at home and it bursts, that's going to be a real issue there. So in any event, so you're going to want to make an assessment of the risk for a rupture. So if it's rapidly expanding over days to weeks, that's one risk factor. And then look at the character of the skin. If the skin looks very thin and shiny, that's a problem there. So if those are the cases, you're going to want to get them urgently to your vascular surgeon for some surgical correction. If it's something that's kind of more stable, doesn't look like that, you can maybe refer them for a fistulogram, and there may be an outflow or a central stenosis which is contributing to that. Dilatation of that may decrease the back pressure and may help those things. So the last thing I'm going to talk about is something called Steele syndrome. In a fistula or a graft, some of the arterial circulation is not going to the hand, it's going through the fistula or graft. So there can be less flow to the hand. So if patients have arterial disease, that can cause ischemia to the hand. So most commonly the patient's going to say their hand feels cold or maybe numb. If this happens, you're going to want to assess the patient. You're going to want to assess the radial pulse. You're going to assess for capillary refill to see if there's circulation there. And then some things to be more concerned about would be, first of all, weakness in the hand. So you're going to want to make sure they have full hand grip strength. If their hand is weak, that's more concerning. Or if there's ulcerations in the fingertips. If that's a more ominous sign. So if this is the case, you're going to want to get them to your vascular surgeon. There's certain revascularization procedures they can have to increase the flow. They can maybe do something called banding to decrease the amount of flow through the fistula or the graft, increase the amount of flow to the hand. Or if in a severe case, they may need to ligate it altogether. So there you have it, fistulas, grafts, the things to look out for, how to assess. For more information, check out bcnephro.com, a link to an article there. And like always, thanks for watching. Grateful for the opportunity to be here, and until next time.